Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On today's podcast, we're talking about GPs with extended roles and how they could help move services out of hospitals and into the community, reduce waiting times for patients, and boost GP retention. I'm talking to Dr. Charlie Andrews, a GP partner and a GP with an extended role in gastroenterology. Charlie is the driving force behind a programme in the southwest of England that trains GPs with extended roles in gastroenterology. This has been the basis for a new framework for GPs with extended roles that's been endorsed by the Primary Care Gastroenterology Society and the British Society of Gastroenterology. In this conversation, Charlie explains how the training programme works and the potential for GPs with extended roles to improve referral pathways and tackle some of the challenges facing the NHS, including workforce issues. He also talks about why the framework should be used by more ICBs to develop GPs with extended roles in gastroenterology across England and how it could provide a model for other clinical specialties to develop GPs with extended roles. I'm really pleased to welcome onto the podcast now Dr. Charlie Andrews. Charlie is a GP with an extended role in gastroenterology based near Bath. He works as a GP partner and has a role working in gastroenterology as an endoscopist in his local area. Alongside his clinical roles, he works for NHS England, developing and leading the GP with an extended role in gastroenterology training programme in the southwest of England, which is what he's here to talk about today. Thank you for coming on the podcast, Charlie.
Thank you so much for having me on, Emma. It's great to be here. I love listening to the podcast. I think the episodes are brilliant. It's an honour and pleasure to be here.
Oh, thank you so much. That's really nice. That's one of the nicest welcomes I've had. First of all, I suppose let's start. How did you become interested in gastroenterology and how did you develop your own extended role?
So my interest in gastroenterology really comes from a personal and professional place. So I think that my first interest was piqued through personal experience of inflammatory bowel disease. So when I was about 15 years old, I was diagnosed with ulcerative colitis, and over the years, I went through multiple different treatments. So I had a really good understanding of being a patient. When I was about 18 or 19 years old, I was studying a history degree in Durham University, and I got very unwell with inflammatory bowel disease, and I had to take a year off, unfortunately. And I went through a number of different treatments and doctors, and I met a doctor called Professor Mike Cam, who just was phenomenal. One of those people that has really good empathy with you, went on your journey with you. And I was really blown away by the effect that a doctor could have on you, and the fantastic sort of way that he was with patients just really inspired me. So I decided to change to medicine. So really it was my experience of being unwell, being a patient that really triggered my interest in medicine. So I then became a doctor after I completed a history degree. Slightly unusual route, I know.
Yeah.
Continued with my interest in gastroenterology. I then had an F1 job on a gastroenterology ward, which was really enjoyable. And at this point, you're probably thinking, well, why didn't you become a gastroenterologist? But my heart's always been in the community, and I just love the holistic approach that general practice takes. The variety of things that you see in primary care is really interesting, and just developing relationships with patients, with families, and understanding kind of that biopsychosocial aspect of them. I always wanted to be a GP, but that interest in gastroenterology remained. And so I looked for different opportunities where I could build that interest. And in 2018, I became a regional clinical champion for inflammatory bowel disease for the RCGP and Crohn's and Colitis UK. I then kept on going to the hospital and saying, look, can I sit in clinic? Can I get some experience here? And I think actually through sort of sheer perseverance and the fact that the hospital just got bored of me knocking on the door, they finally allowed me to come in and sit in. And it really built from there. I then started doing some endoscopy training with them. And then in 2019, I started doing a diploma in gastroenterology and spent time every week sitting in clinic in my local hospital, the Royal United Hospital in Bath, and just built up my experience that way. But over the years, I started to develop experience in outpatients. And now, as you said earlier, I do endoscopy as well. So I'm sort of deepening my understanding and roles within gastroenterology. So it really wasn't a simple process, but because I was very motivated, I managed to get there. And as you said, they're a flavour of what a GP with extended role job looks like. I am, as you said, I'm a GP partner at a fantastic practice called Soma Valley Medical Group just outside Bath. I am an endoscopist, and before that I spent about 3 years working in gastroenterology outpatients in my local hospital. I love education, so I run a podcast called Ingest. I do some research work in gastroenterology, so I run what's called a capsule sponge pilot in my local practice. So I've got lots of different things that I enjoy doing, and I think it really enriches all of my career aspects. All of the different bits that I do really brings a lot to the table for me, and I love doing it. So that's my journey towards it.
That sounds like a really well-rounded portfolio career you've got there. So you've been running a project in the southwest of England for the past 2 years to train GPs to take on an extended role in gastroenterology. How did that come about, and what was the aim of that?
When I was trying to become a GP in extended role, it really was very much a DIY job. There weren't very many GPs with extended roles in gastroenterology out there, primarily because there was no real pathway in place. And what I thought was, well, maybe we could create a pathway and actually allow others to do this. And so I approached two extremely forward-thinking gastroenterologists in the Southwest with links to NHS England, Paul Dunkley and Mark Feeney. And so what we set ourselves the aim of doing was to create a standardised pathway to develop a GP with an extended role, to include educational, clinical aspects, and also a portfolio for them to demonstrate the competencies. We really wanted to create something that was sort of gold standard and something that GPs could follow. And we wanted to then start to create a network around the southwest of England of like-minded GPs, sharing innovation, supporting each other to develop this role, with the ultimate aim of creating innovative roles working at that interface between primary and secondary care, so that we could start to rise to some of the challenges that we all know are out there at the moment: significant waiting lists, difficulties reaching that 18-week target at the moment, and also workforce challenges, both in primary and secondary care. So within secondary care, we know that the gastroenterology consultant workforce is not expanding at the rate that it requires in order to meet the demand that we're seeing. And obviously within primary care as well, we have significant challenges. And what we wanted to do was create interesting portfolios that GPs wanted to do that actually would have a really important impact on recruitment and retention. And so there were lots of different reasons why we wanted to do it. But as I said, the ultimate aim was to create this standardized pathway.
What does the training actually involve? How does it kind of combine the educational and the clinical side of things?
So this is a 2-year training program. In year 1, the GP will do both a clinical and an educational aspect to their training. And then in year 2, the clinical training continues, but the education ends. So in terms of the clinical side of things, what we do is we link the GP up with a supervisor, a gastroenterologist in the hospital, who will work alongside that GP for one clinic. That supervisor will support them, discuss cases, and what the GP will do is they'll complete workplace-based assessments, so things like case-based discussions, reflections on practice, and these will be uploaded to their portfolio. The second aspect is educational, and what we've created is a very bespoke 12-month educational program for our GPs. This takes GPs from the upper GI tract all the way through the system, covering everything that they're going to need to know as a GP in extended role to really support that clinical learning. This is all delivered online, so we deliver it through an educational portal, and this portal is run by myself and someone called Jerry Budden, and we run it through the Primary Care Society for Gastroenterology website. And essentially what this program does is it allows GPs to do their learning in a very flexible way. So we have lots of different learning styles accommodated. So we have things like written assignments, interactive case studies, recorded webinars. We also do live tutorials as well. And it just allows GPs to fit it in around their really busy life. And this online portal that we use to educate the GPs also acts as their portfolio. So they can upload their workplace-based assessments, they can upload reflections, they can upload their end-of-year reports. So we have an appraisal document that they upload to their portfolio as well. And this just helps them to demonstrate some of those competencies that they need to do in order to pass through the programme.
You mentioned there's a supervision there as part of the educational programme. So you've got the gastroenterology specialists who are involved with that. Does that kind of supervision continue after people have finished the programmes? How does that work once they've been through the 2 years?
The GP works very closely with their supervisor during their training, and they build up a very strong kind of rapport. And actually, interestingly, we get lots of comments about two-way learning. The hospital clinicians find it really helpful to get a bit of a better understanding of primary care in the community. And obviously the GPs benefit enormously from the knowledge that the gastroenterologists provide. But it's a really interesting experience. And I know that on the podcast previously, you've had discussions around, listened to a fantastic episode about that primary care interface and how you can strengthen the bonds and the communication between the two. And this is a really nice way of doing that, because actually it just gives you that really deep understanding. once you've come off the training programme, it's very important for that GP to remain within a suitable clinical governance structure, likely be very much linked to that gastroenterologist they've been working with.
How does it kind of impact on secondary care? How does it impact on other GPs?
It's a really good question. And what I would say is a bit of a disclaimer before I answer this question. We're 2 years into the programme. Our first trainees are about to come out of the programme and move into their roles. So what I can talk about is kind of what's the aim, where are we heading towards? I can also talk a little bit about some of the examples that are out there, actually, because there are really great examples of GPs with extended role in gastroenterology doing really interesting things. So the aim, once trained, is that these GPs will get upstream of demand, really. Somewhere about that sort of referral management. Can we actually bring things out of the hospital that don't need to end up on a waiting list for secondary care, which just allows secondary care to see those patients they really need to see? There's also thinking around the advice and guidance role. We have one of our GPs who's coming out of training, and it looks like he's going to have an embedded advice and guidance role, which is a really interesting area, and a real focus at the moment is around advice and guidance, as we all know. And so a GP starting to work across maybe a PCN or several PCNs providing advice and guidance could be a great role for that GP. Also looking at things like community clinics, as I mentioned earlier, and also just bringing that expertise into the GP surgery. One of our GPs in their first year of training commented that their advice and guidance referrals into gastroenterology had reduced by about 15% just by having that GP in the surgery. So what we're trying to do is bring that expertise out so there is someone that you can talk to when you've got that slightly more advanced gastroenterology question that perhaps doesn't fulfill kind of a need for a referral. There are some examples of GPs working at the interface already. There is a fantastic referral management service in Sheffield called Cases. And what they found is that by having a GP with an extended role working at that interface, looking at all referrals coming into secondary care, they can reduce referrals by about 17%. So that's quite a big reduction in things going through to secondary care by simply providing advice back to the GP. There's also a community clinic in Bristol, which is run by a GP with an extended role in gastroenterology. So they see about 850 patients per year, which is quite a significant number. And more than half of them are discharged back to the GP after that initial consultation with an advice and management plan. So more than half of people going through that clinic not requiring onward referral. There has been a community fit negative clinic for symptomatic patients in Norfolk. They did a great study looking at about 200 patients that had passed through their clinic. And they found that actually less than 7% actually required an endoscopy after they'd seen a GP with an extended role in gastroenterology. Most of them just needed advice, guidance, and maybe a couple of other different tests to try and help that patient, because they've still got symptoms, but they're fit negative. So they don't fit a pathway, but actually they still have needs. So these are really interesting examples of what we could be doing if we had that workforce. It shows that sort of potential benefit, but we really need to build the workforce to deliver that. That's what we're trying to do at the moment.
How does that work? So you've got a GP with an extended role who is providing those clinics, maybe those advice and guidance things. While they're doing that work, are they employed by the hospital trust to do that? They're not being employed by the practice where they work for that session, are they?
This is a really interesting question, Emma, because it's a different approach to the entire system. And I think that funding pathways perhaps don't always fit these new innovations immediately. And so I think it's difficult to say, where does that funding come from?
Yeah.
I think that NHS England probably need to have a look at this and say, well, if we want to build that interface, we need to start thinking about where that funding comes from. It potentially could come from secondary care. It is having an impact on secondary care waiting times. We need to really look at the whole system and say, what do we want to achieve and how are we going to do that? And therefore, how are we going to start funding the different areas that we want to do?
When patients see GPs with extended roles, obviously this often means that they're seeing people in the community rather than having to go into hospital. So what's their view on it?
The informal feedback's always been very positive, but as long as those patients, you've got the right patients seeing them, it could make a huge impact. So someone with functional bowel disease, a GP is really well placed to manage that, because actually our whole role is looking at the holistic side, seeing how X fits into Y and how the family dynamic works. I think we're really well suited to that, and we can provide a really good service around that. But as I said, the informal feedback that we've had from patients has been very good. But, in terms of how this could potentially benefit patients, we're looking at hopefully quicker appointment times, closer to home. I think that things closer to home are always appreciated.
There's also been some analysis of the costs involved with setting up the programme and the potential savings. What did that analysis find?
So we have done a formal evaluation of our program. And I think that this is the first time that this sort of evaluation has been done, and it's produced some really interesting findings for us. We set ourselves 3 questions. So we wanted to ask ourselves, does the program effectively prepare the GP for their future role? Do the existing models have a positive impact on patients in the healthcare system? And then finally, we want to look at whether the GP with extended role program that we set up is cost effective. So in terms of that cost effectiveness, we calculated the cost of training a GP with extended role over the 2-year program, and we took into account clinical activity. So we kind of offset that against the cost, because the GP is providing quite a lot of clinical activity in a parallel clinic in secondary care during training. And towards the end of the training, they're probably running more or less a consultant length clinic alongside their trainer. And so we wanted to work out how much it costs overall. And when it's delivered in the Southwest, we found that the approximate costs over 2 years was £25,000 for the entire program, 2 years. But what was really interesting is that we started to scale it up. So we said, rather than training, as we are at the moment, 4 GPs in the Southwest region every year, we said, well, what if we spread this nationally across the 7 different regions of England? And we were training 28 GPs every year. And we found that there's definite economies of scale. And what we found was that the cost dropped significantly to about £18,000 over the 2 years if you start to do this at scale. So it just really shows that there's a clear advantage of a coordinated national approach to this. And then what we finally calculated was how many secondary care appointments does the GP with extended role need to prevent to pay back their training cost over a 5-year period. And actually the threshold is remarkably low. So it's between 0.85 and 1.37 outpatient appointments per week, depending on the scale of the program, either Southwest or national. I know that you can't really split patients into 0.85 and 1.37, but you know what I mean? It's showing that, if you spread this nationally, less than 1 patient per week needs to not go to the hospital as a result of the GP with extended roles intervention to actually offset the cost of training.
You talk there about rolling it out nationally. There is a national GP with extended role framework that's been approved by the British Society of Gastroenterology and the Primary Care Society for Gastroenterology. Is that something that's come out of the work that you've been doing in the Southwest?
Yes. So this framework document, which was really important, this felt like an extremely important point to get to, has been the product of years, really, of working between the Primary Care Society for Gastroenterology and the British Society of Gastroenterology, of building that relationship and then starting to work together collaboratively to create a shared vision of what a framework would look like. And throughout 2024, I was part of a working group with the British Society of Gastroenterology where we were sketching out and started to build this framework. And it really draws a lot on the frameworks that are already out there. You may be aware there are some fantastic frameworks for GP with extended role already. So the dermatology team have done that, MSK and rheumatology and allergy. So we drew a lot on what they'd done, but we built on that to try and make it gastroenterology specific. And what we created together and published it at the end of 2024 was a national framework, which is really trying to outline the gold standard for what we feel is appropriate in training a GP to this role. And that framework contains a curriculum, so a curriculum that's based on what we feel the GP with extended role should know. It's really important to point out that we're not trying to make mini gastroenterologists here. Gastroenterologists have fantastic skill set and very advanced knowledge in certain areas. What we're trying to create is someone who can work at that interface, who has a very defined role, but very important role within the system. And so the curriculum is very much based around that. And we also have a competency framework. So it's really a competency-based framework. And the 3 main competencies are to run an outpatient clinic with appropriately selected patients, provide leadership and education in the community in gastroenterology, and also to work across primary and secondary care, building those relationships and supporting pathway design and development. So those are really the competencies that the GP needs to begin to develop and demonstrate through training. We also outline pathways and ongoing appraisal needs within that document. It's important to say that it's not an accreditation pathway. That is not what we've created. What we've created is a gold standard framework. Accreditation should be organised locally, as I've already mentioned. You work through the programme with your local trust, and then your trust will then decide whether you are ready to move into that role at the end of that training. It's also not a scope of practice document. We do provide sort of suggested potential roles, But what we wanted to do was keep that role very flexible, because what one area needs, another area might well not. I've got a couple of GPs on the programme who are working primarily in hepatology, so focusing on the liver side. I have one GP who's looking at running an iron deficient anemia service, and others that are doing more general gastroenterology. And it really depends what the local area needs. So I think being really prescriptive around the role was not what we wanted to do. We wanted to keep it broad so that that role could be tailored to what every area needed.
Now that framework is there, I'm assuming you would like to see this model sort of rolled out more widely across England. You've kind of touched on that already. But what kind of support needs to come from NHS England and from ICBs to get this sort of thing off the ground, to make sure it's kind of across the country?
The programme that we've created can be delivered anywhere. You need to have local specialists supporting the GP with the clinical aspects, but the programme itself is able to be run anywhere. And I would really like to see it being run nationally, because we need to start to build that network. And actually what we're finding in the Southwest, it's great having a network of GPs sharing ideas. We're all doing quality improvement work and just supporting each other. And I think it could be run nationally. And I would like to see it being run nationally, because I think that without the workforce, we can't develop those interface roles. What does it need in order to do that? I think it needs central leadership, some leadership saying this is the direction of travel that we want to go in, and then outlining how we're going to get there, how are we going to start developing that, how are we going to fund that. And I think that that probably does need to come from the national team, from NHS England. And I think also ICBs need to look at it and say, well, there is an investment here, so we need to invest, but this is an investment to develop. There is a cost, but actually, once that GP is in position, you can see significant benefits across the healthcare system. And so I think it needs, as I said, that leadership centrally, and also ICBs just to recognise that this is actually a potentially really interesting role that can have significant benefits across the system.
Just if people are listening to this and thinking about it in their area, what would you say have been some of the key factors behind the success of your scheme in the Southwest?
So I think in terms of getting this off the ground, the things that have been really instrumental are having strong allies and support. So I mentioned earlier about Mark Feeney, Paul Dunkley, also Charlotte Taylor from the NHS England team. They've been really supportive, both in terms of providing support and guidance to me, but also in financial support. NHS England helped pump prime this programme, and I think without that, I'd have found it extremely hard to get this off the ground. So I think having allies and early adopters and people who've got that vision has been really instrumental in getting this going. Strong engagement across primary care, secondary care and ICBs has been vital. So before we started the programme, I think I spoke to nearly every trust within the Southwest and actually every LMC as well to talk to them about what we were planning on doing, and really getting interested secondary care colleagues involved has been really helpful. So finding the trusts that really wanted to take this forwards has been so helpful. Also, LMCs were really supportive of this, actually. And I was concerned that they might say, well, we don't want to take GPs out of primary care. But actually, I think they recognise that the portfolio is really important for recruitment and retention. And so actually, that's been really helpful as well. Finally, perseverance. It's almost like having another child. I see this programme as something I'm so deeply invested in. I haven't given up. And there have been difficulties at times, and you can get disheartened when things aren't going quite as they should, or when the response isn't quite what you want. You've just got to persevere and keep going and pushing it forwards. I want to get it out into the world because I believe in it so much. I think you need to have people leading it, is probably what I'm saying, is people who are deeply invested and just want to go for it. That's probably helped. I think my blood, sweat and tears have probably been part of the factor in getting this off the ground as well.
The model you've developed is very much for gastroenterology, but do you think the kind of framework that you've kind of put in place for that specialty, do you think it could be used by other specialties to develop GPs with extended roles?
I do think it is. And I start this answer by saying that actually there are some really good frameworks out there already. And I mentioned a few already. So the dermatology side, they really went first with this. And I think it was in 2019.
Yeah.
They've got quite a large network of GPs with extended roles in dermatology working at that interface. Later came the MSK and rheumatology frameworks, and also an allergy framework. I think that the thing that's slightly unique about what we've done is that we've created the entire program. So it's not here's the clinical aspect, go and find the educational program yourself, go and find a university diploma or something like that. What we've done is we've created the entire thing. So we've got the educational program, we've got the clinical aspect. Once you're on the program, you run through and it's all there. So I think it's slightly unique in that it's an all-in-one program. And what we've really tried to do is focus on what does that GP with extended role need to know. But I do think that that sort of model could certainly be seen across other specialties, actually. For example, what does a gynecology GP with extended role need to know? You could begin to really create a program that would fit that, and you could potentially use a similar model to what we're delivering at the moment.
This is all very, very topical at the minute because we're waiting for the 10-year plan to come out. It's likely that's going to have a big focus on this moving of care out of hospitals towards the community. GPs with extended roles fit into that policy. Do you think there's going to be a bigger role for GPs with extended roles in the future?
I hope so. When you look at the direction of travel, you sort of look at the big three NHS England Department of Health priorities, one of which is being that community shift. I feel like we have to be realistic about how do we deliver that. GPs extended role potentially fit into that picture. I'm not saying that they're the entire picture, but I think they could be one of those pieces of the puzzle that could help us to do that. The January 2025 Reforming Elective Care for Patients document was really interesting, and actually it very much focusing on that community approach, things like a phased approach to optimizing clinically led pathways, reflecting that required shift of hospital to community. And actually they also commented on gastroenterology specifically as one of 5 specialties where they really need to start to develop integrated pathways across community, primary and secondary care. So I really think that there is this desire to start to deliver that. But how do we do that? Well, I think, as I said, GP's extended role could be part of that solution. They could be one of the pieces of the puzzle that allows us to do that.
Do you think they could help with reducing waiting lists? Do you think that's a way to maybe encourage integrated care boards to get on board with the whole idea of GPs with extended roles by selling it to them that they can help you cut your waiting list?
The GP with extended role, if we can get them upstream of demand and start to manage that demand in a different and better way, potentially, I think it will really help us to kind of get to that goal of the right person at the right time. You know, who is the right person for this patient to see, to allow the specialists to see those patients that really need it and allow others to see the patients that potentially don't need that level of support, but still need some input. So I do think that by building this interface, we can begin to develop that system. When I was a patient with inflammatory bowel disease, I did find that it was quite hard to get into the hospital setting. You know, there were reasonable waiting lists, and things like inflammatory bowel disease move quite quickly. And so we need to ensure that people who have kind of a more urgent need for care and more specialist care can get that. And this could be one of those ways to allow us to do that by bringing that demand that doesn't need to go to the hospital into a different setting.
One of the other benefits of this is about allowing GPs to have portfolio careers. It is giving another opportunity for GPs to have those careers. And that really could help with retention. I mean, what's your view on that?
Recruitment and retention was certainly quite high on my list of priorities when I set this up, because actually I love what I do. I love having a varied role, and I know that others enjoy portfolio careers, but if there are no pathways to allow you to do that, to develop that interest, it's very difficult to do. So, as I said, that was one of the motivations for setting up this program. But the experience that we've had of setting up the program has been really positive. When we advertised for the last 4 roles that we advertised over the last year, we had 12 GPs applying for each role, which is just an enormous number of people interested in this role. So there's definitely interest in it. People would like to develop that role. We come into the community because we are drawn to the community setting. We want to work as primary care colleagues in that holistic sort of approach. But sometimes you just have that itch to sort of still have some hospital medicine. I think also it's a potential for different ways of working. So I quite enjoy doing endoscopy. It's a slightly different thing. There's also potentials within this for, you know, more flexible working, remote working potentially as well, looking at triage, referral, etc. So I think that the role we've shown and seen has been really popular when we've advertised it. And the benefits around portfolio careers, I think we know are there.
How important do you think it is to have a framework for these kind of GP with extended roles?
I think the structure is really helpful. As I said, I found it very difficult to get to the point where I could work within a sort of specialist or sort of extended role. And so I think just having a pathway in place is really helpful. It just means that a trust or an ICB can look at this and say, okay, this role fits what we want. This is how we can get there, rather than having to think, well, we'd like to get there, but how are we going to do that? It just removes one of those barriers, really. So I think having a pathway is really important.
You've talked quite passionately about this, but what would you think has been the most rewarding aspect of developing and implementing this programme for you personally?
One of the really rewarding things is taking a plan or a vision or a thought or an idea from that drawing board and then actually delivering it has been fantastic. And it takes a team to do that. And there are so many people that have helped to bring that idea from where it is to where it is now. Think how we could improve the system, build it, and then deliver it. Fantastic. It's also fantastic being part of something really innovative, something that's slightly different, but with lots of potential. So I've really enjoyed being part of that. The impact that it has on those who are going through the programme. So the feedback that we get is so fantastic. It's seeing GPs who are energised, enthused, they're really happy. And I love reading that feedback. So that, to me, it's great. The other side of it is looking at some of the feedback from the hospital teams as well, and seeing them saying that, they really look forward to their session with the GP because it makes them think about things differently. It's just fantastic.
There's probably lots of GPs listening to this who might not be necessarily thinking about GPs with extended roles, but they might well be involved with discussions in the coming months and years about how to redesign care in their area as part of neighbourhoods and things like that. Have you got any tips you could give people about how to start with that, what to do if they have kind of some passion project that they think could help improve things for patients?
I touched on this before, and I do think that engagement and networking are vital. That's so important in getting these things off the ground. Primary care, secondary care, ICBs, I think you just need to start to engage, build those networks. And as I said earlier, find those people who are going to help you develop it and deliver it. So who are those allies? Who are those early adopters for change? People who've got that interest in doing so. So I think that those are the really vital things, to be honest, is just building up your network and finding your allies and people who want to share that vision and take it forwards.
That's really good advice. How would you like to see your programme develop over the next 5 years or so? What's the big long-term aim for all of this?
One of my big focuses is supporting the people who are in training at the moment and bringing them through the programme and starting to develop their roles in the Southwest. So that's a really important aspect of it. So we've got them coming out of training now. We're starting to bring them into their community roles. So I want to help them to do that, help them to deliver them. The next thing I want to do is really grow this beyond the Southwest. We have a national framework. We have a programme that can be delivered nationally. I want to see if we can start to see this spread around the country. And finally, I want to look at whether this could be a model for other specialties. There's lots of really interesting things being done in GP with extended role world amongst different specialties, but I think we're all doing it in pockets. Can we bring this together? Can we start to have a coordinated approach to what we're doing? I think we can. And over the next few years, I'd really like to see that leadership developing and coalescing around it and starting to build that interface across all specialties. If people want to contact me, they can contact me via email. It's my name, charles.andrews@nhs.net. I'm always really interested in hearing people's thoughts around these sorts of things. And if people are interested, I'm always happy to see if we can help to develop that further.
Thank you so much, Charlie, for coming on the podcast. I really appreciate your time.
It's been a pleasure to talk to you, Emma. Thank you.
Well, that's it for this week. Thanks for listening, and thanks again to Charlie for taking the time to talk with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.